Great. All right. So I feel like we've been kind of building towards this topic right from the beginning. We really want to just get very specific about what we mean when we're saying addressing racism as a root cause of birth disparities. And I'm so excited for this final presentation that I have brought along one of my incredible colleagues, Peja Edwards, who is actually from Riverside. So I brought a local girl home on Zoom, and she's going to be helping me present today. So Peja is a doula, a certified lactation educator, and she also is a public health professional. And so I'm really excited for her to be able to talk to y'all. So we're going to actually be doing some polls today to make it a little bit more interactive for you guys. And to start with, we just kind of want to do a little bit of a pulse check. So Pei, will you go ahead and launch the poll? So we would just kind of want to know, how are people feeling? So can you let us know how you are feeling today as you think about taking on racism as a root cause of birth disparities? And we welcome all experiences here, so you don't have to pretend for us. Great, we have about half of people have answered. So if you don't see it, there should be a little icon at the bottom of your screen that says poll. And then all you have to do is go ahead and click your answer and hit submit. I'm going to give it about 5 more seconds. Great. So it looks like we have people who are inspired on this call, which I'm thrilled about. And we have equal numbers of people who are excited, energized, tired, which I get. And I also just want to validate the scared and the meh, because we've all been there. So all people are welcome. Great. So also, one of the things that we think is important, especially at this phase in the training, is that we kind of know who's in the room. And we want everybody to practice kind of normalizing this idea that race exists and that racism is an issue. So if you could please put into the chat your name and your agency or clinic or hospital and your racial identity, however you identify it. And I just want to make a note that I'm saying racial identity and not nationality and not ethnicity. And many of us don't feel very well described by our racial identity, but nevertheless, very often this is the way in which we're categorized. And so you can also please put in your preferred pronouns, and we'll just watch those slowly trickle in as I continue. Okay. So there was a study that came out a few years ago that actually looked at birth outcomes in Northern Europe. And one of the cool things about Northern Europe is that because they have national health care, they can follow people's health outcomes from birth through the end of their life because they have incredible record keeping. And so somebody did a study basically to kind of understand what was happening to babies who were being born early in the long term. And basically what they found is that being born early, even just a few weeks early, puts you at higher risk for impacted development. Okay, I'm sure most of us knew that, but it puts you at much higher risk for being unready for kindergarten. Increased risk for socio and emotional impact in addition to cognitive impact on development. And then that in turn puts people at higher risk for not achieving in the educational sphere or the employment sphere, which in turn puts people at higher risk for poverty, which in turn puts people at higher risk for toxic stress, which is one of the main drivers for these unexplained preterm births. And so what basically this study was able to demonstrate is this cycle that we are unfortunately in, especially in the Black community, where we have racism driving these preterm births. And once a baby is born preterm, there's a way higher risk that that is going to be passed on intergenerationally. And so we have to interrupt this, not just because it's racist, not just because Black babies and Black mamas deserve to have a fair shot at health, but also because our overall economic well-being in this country depends on us figuring this out. So we assert that we have to, if we want to figure this out, we have to address racism directly. We cannot continue to assume that if we get mamas that are experiencing birth disparities into prenatal care early, then that will solve everything. This is bigger than a clinical issue. To kind of illustrate this point that we have to address racism directly in order to close disparities, I want to use this analogy that got popularized last year, this analogy of a Monopoly game. So I want you to imagine that there is a family of 4 that's playing Monopoly. But I want you to imagine that only 3 people in the family are allowed to actually play Monopoly, and they actually send off one of the younger siblings to go and do chores while the family is playing. And the family's having a grand old time, and they're collecting their salary as they pass go over and over again. And as they accumulate money, they're buying properties, and now they're building hotels on their properties. And eventually they're like massing empires. They're like hiding the $500 bills underneath the board so they can hoard them. And they've really, like, when they feel satisfied that they've built up a huge mountain of wealth, then they invite in that other sibling to come and join the game. And I just want to ask you, like, do you think that that other sibling has any chance of catching up? Of course not. But this is just an analogy. In real life, we're not talking about, 4 hours of doing chores, right? We're talking about 400 years of brutal racialized exploitation. But the analogy stands, which is that there's just no way that Black people in the United States can magically bootstrap themselves out of centuries of oppression. We have to be willing to address racism as a root cause if we ever want to see a narrowing of the disparities. But a lot of times when we talk about this idea of addressing racism as a root cause, it is such a big problem that people become overwhelmed and can't kind of imagine, like, what is their role in this? And so our team at Expecting Justice tried to develop a framework to better illustrate for folks what we mean when we're saying we need to address racism as a root cause of health disparities. And the way how this framework works is that there's 4 criteria that you need to meet with your intervention to be really addressing racism as a root cause to the best of your ability. So let me introduce to you each of these criteria that we need to see in our interventions. The first criteria is that our intervention has to be long-term. Racism has been around for centuries, and so it's ridiculous to think that an intervention that lasts 6 months or even maybe a couple of years is going to have any kind of meaningful impact on such a long-standing system. So when we're addressing racism as a root cause, we need to identify pathways for sustainability in the long run. A lot of times what that means is new legislation or identifying a governmental source of funding. I also just want to name that sometimes it can be really difficult to try something way outside the box and identify a long-term funding stream immediately. And so if we have to do a pilot, which we often do when we're trying something new, we need to identify a source of sustainability for that pilot before we even start. If there is no clear way that this pilot can be sustained, then we need to question whether or not it's important to actually be doing that pilot. The next criteria is that we need to see a precise impact. By that, what I mean is that we need to be willing to be brave enough to name the specific racialized group that we're trying to impact. Very often, because most of us in this country have been taught that to be unracist, you need to be colorblind, you need to not see color. And so for that reason, we often will say things like, this is for all people of color. Or more recently, I've been hearing people say, this is for BIPOC people or BIPOC people. And while there's something important about naming solidarity for people of color, what is also important is to recognize that not all people of color experience racism in the same way. The way that racism might be impacting, for instance, a Vietnamese immigrant might look very, very different than how racism might be impacting a Lakota person living on a reservation. And to assume that it's hitting them all the same and that therefore we can just have interventions that, reach people of color is really dismissive of the ways in which racism has been formed in a very complicated way for different groups of color in this country. So if we want to be addressing racism as a root cause, we need to be willing to be precise in our impact. And the best way to do that is to go to the communities that we're trying to work with directly and ask them, how does racism manifest here? What do your racial barriers look like? And we pay them for this expertise and for this knowledge, and then we design directly for them. And if there's multiple groups of color that you need to work with, then you might need to go to multiple people of color community listening sessions and identify multiple ways in which the intervention is going to be rolled out so that it's meeting the specialized racialized barriers that different groups are having. And just to really illustrate this point, I want to take an example like, federal scholarships for college. Like federal scholarships for college should be providing opportunities for folks who wouldn't normally have an opportunity to go to college. But the problem is, and I'm sure all of us know this, that not everybody is equipped even in the same way to take advantage of these federal scholarships. And who is equipped and who is not is very much based on race and how racism has impacted people. And so when we have a universal colorblind intervention like federal scholarships for college, we continue to see disparities in who's actually attending and graduating from college based on race, because we were not willing to examine in various racialized communities, well, what is the actual barriers in addition to money for you not going to college? And I think if we were to start to explore that, we might find that if your parents didn't go to college, it's really hard to get through the application process. And so people who have been historically alienated from college, like that might be the issue. Or conversely, if your parents don't speak English, that might be a totally separate issue, a different racialized barrier that needs to be addressed separately. So we need to be willing to have a precise impact when we're addressing racism as a root cause. Okay, the third criteria is systems change. We need to be willing to address racism at the level of structures and systems if we want to actually start to narrow racial disparities. Very often, and this is so much because of the ways that we've been taught in our different professional schools, but very often our interventions are around changing or helping people, helping mamas get their medicines, helping mamas get to clinic, helping mamas get enrolled in insurance. But none of those interventions are having the impact of closing the disparity. And the reason why is because Black mamas, there's nothing wrong with us. We do not need to be fixed. What needs to be fixed is the systems and the environments in which we need to birth, right? And so when we're addressing racism as a root cause, we need to be focused not on changing people, but on changing policies, on changing systems, on changing our internal work practices so that it is not so stressful for people who experience racism to engage with these systems. And so if we are trying to undermine these disparities by addressing racism as a root cause, we need to really be willing to do this kind of systems change and move a little bit away from these individual level interventions that are focused on trying to make people more resilient or more able to withstand systems of racism. And then the last criteria, if we want to address racism as a root cause, is reparations. And I know that when I say that word, that can be controversial for some people, but I just want to take you back to that initial Monopoly slide as a reminder, like there is just no magical bootstraps that Black people, that Indigenous people have that can magically put back what it amounts to $17 trillion worth of wealth extraction for both communities, right? $17 trillion for the Black community, $17 trillion for the Indigenous community in this country. We cannot magically put that back by ourselves. And so if we want to address racism as a root cause of birth disparities, we need to figure out some mechanism for providing reparations to do that repair work. 40 acres and a mule, I'm here for it. But I recognize that that is not always feasible, especially if you're like a clinic or a hospital. So what I would offer is that one way we can do reparations in these communities is by looking at the flow of resources, power, and opportunity. Very often, we inadvertently hoard those three things within our white dominant systems instead of actively trying to figure out how we can transfer those things into community. I'm going to give you an example from my own health department. So let's just say that the California Department of Public Health comes out with a new funding stream for addressing racial health disparities, and local health departments have 3 months, maybe 2.5 months to respond to this, RFP for this new funding stream. And, 3 months is not very long, especially in like public health department time. And so before we know it, we're almost at the deadline. And now we don't have time to engage community and find out what community wants us to do with this money. And so we're just going to rely on our own expertise and we're going to just decide for them. And in doing that, we have now officially hoarded all of the decision-making power for ourselves and shared none of it with community. And then inevitably, we're going to be like, oh, we're going to need some new people to work here. to be able to do this new intervention that we just chose for community. And so we're going to start creating new jobs. But because of the ways that government works, chances are these are going to be civil servant jobs with all of these rules and lists, et cetera. Who can get on this list? Who can even apply for this job is going to be very esoteric and confusing. And so as a result of these systems, chances are these new job opportunities are going to be occupied and taken advantage of by people from racially privileged groups, because that's who's probably going to have access to these governmental jobs. And then we're going to probably go into community and we're going to roll out this program, give these services that they never even asked for. And we're going to have to pay ourselves like indirect fees and fringe benefit fees. And we're going to have to pay these people to do the work. And so all of the dollars that the state brought in is going to mainly stay in our pockets, and none of that is going to go to community. And so effectively, despite the fact that probably we were given a bunch of money to address racial health disparities, chances are our white-led institution probably hoarded all of the resources, power, and opportunity that resulted from that new funding stream. And that's not because we're terrible people in San Francisco or because we're horrible racists. It's just how business is often done and how our systems are set up. But you can see how that just kind of perpetuates marginalization. So when we're addressing racism as a root cause, we need to be digging in our heels, making sure that we allot the appropriate amount of time so that we can be conscientious at every step of how can we be shifting decision-making power into community? What mechanisms can we put into place? How can we create job opportunities or other career development opportunities from this intervention for folks in community? How can we make sure that a certain percentage of the dollars that are coming through end up in the pockets of folks from community? We try to, when we used to have in-person meetings, only hire caterers from the Black and Pacific Islander communities that we are specifically targeting with our interventions as a way to be addressing racism as a root cause in all of our actions. How do we use these dollars and put them back into these communities? So when you take all four of these things and you put them all together, we think that you have the racism as a root cause approach, or we call it in shorthand an RRC. We like to call it that because we want it to be a thing, like RCT, randomized controlled trials, are a thing. We want RRCs to be a thing that people just regularly do and refer to. I can say that doing an intervention that includes all four criteria is not easy. So I will say that including one criteria is better than two, including some is better than none. Having three is better than two. Having two is better than one. And so just looking to see what you can do if you already have an existing intervention to start to shift it so that it can include some of these criteria, or if you're starting fresh, or if you're issuing an RFP or something like that, how can you incorporate these criteria into it? If you're doing strategic planning, is there a way that these can kind of be your guiding principles through your strategic planning? So just trying to think about how can whatever work I do incorporate some of these guiding principles so that we can be addressing racism as a root cause of birth disparities in our work. So I am going to, with that, take us to another poll question. So go ahead and please launch the poll, Pay. And the poll question is, based on what we just got through discussing about this RRC framework, this racism as a root cause framework, can you see some areas of improvement for your own clinic? So please go ahead and select what feels real to you. And when you've gotten the right answer, then go ahead and hit submit so that we can all see it. And I'm going to give everybody about 10 more seconds to answer this poll, and then I'll share it out with you. Okay, 2 more seconds, get your answers in. Great. Well, this is reassuring. I love it. There are no no's, which is my favorite. I love it when people don't tell me no, so thank you, Inland Empire. And I love that there are so many yeses, even better, so wonderful and amazing to those people who are already doing the work. So great job. We at Expecting Justice were so enthusiastic about this framework that we went ahead and had it published last December in the Journal of Pediatrics. So if you Google racism as a root cause and pediatrics, we also worked with the Journal of Pediatrics to have it not be blocked behind a paywall. So anybody should be able to access it. If you are like, what was the third criteria? I just can't remember. You can find it at any time on Google. But also now that it's in the Journal of Pediatrics, what we have found with a lot of our partners is that it's real. And so, like, for instance, if you're trying to do an anti-racist intervention and your board doesn't understand why it has to precisely target one group, you can give them an academic article to help them understand why that might be the case. So I will leave that, if that is helpful for you guys, up for one more second in case you want to try and find it in the Googles. And Pei, if you don't mind throwing that link maybe in the chat, even better. All right. So actually, I will put it in the chat because the next thing that we're going to talk about is what this might look like in practice.
Thank you, Zaya. Hello, everyone. So something that we like to do is give real life examples. So what might applying or what might an RRC or racism as a root cause approach look like in practice? So we have a few real life examples for you. Next slide, please, Zaya. Alrighty, so here we have a one-pager from the California Department of Public Health, and it's full of tips for Black women and what they should know to reduce preterm birth. It was released around 2017, right? And something that I want to call your attention to is really looking at how you can reduce your risk of premature birth. So it specifically says, sorry, next slide. Yeah. So one of the things that it says is to take a daily vitamin. Next thing is go to the doctor. Next, don't smoke. That's bad. Eat healthy and exercise. Make sure everyone helps you. Having a baby is tough. Yeah. No. Right. So something that I also want to kind of really pay attention to, if you go back to the previous slide, is what all of these things have in common is that they are all based on individual behavior. So what we have talked about the racism as a root cause approach is that we're moving away from individual behaviors. That means blaming the individual for the disparities that they are experiencing, because we know that by introducing programs like this, whether it's access to getting to clinic, whether it's access to healthy meals, right? Everyone loves to do a nutrition program, right? We know that these disparities still exist. Why is that? That's because racism is the root cause of these disparities. Next slide, please, Zaya. Okay, so here we have a little bit of data for those of you who are more data inclined, right? And it shows the percent of live births in San Francisco for preterm birth between 2014 and 2018. And what I want to call your attention to is that for the most part, the preterm birth rate, especially for that of Black women and birthing folks, actually increased, right? It went from 15%, went down a little bit, 2015, 2016, and then it started to go back up 2017 to 2018, while other ethnic groups pretty much stayed on the same scale. But once again, calling attention to it that Black mothers and Black birthing people are experiencing the highest rates of preterm births, regardless of interventions like this one pager from the California Department of Public Health that are focusing specifically on individual behaviors. Next slide, please, Sarah. Alrighty, so is it an RRC? Alrighty, so we're actually gonna, go ahead, Zaya. Thank you, Zaya. Alrighty, so does this involve long-term sustainable investments? So we have a no, we're getting some mixed signals here. All right, looking good. Everyone's like yes, everyone's like no, someone's like I don't know. I'll give it a few more seconds. 2, 1, ending poll. Alrighty, so we have about 47% of you that says yeah, that say yes, and about 30% that say no, and then 23% are saying no, not sure, please let me know. So go ahead and click on the next animation, Zaya. No, this is not a long term. It does not address the long-term construct. So health education interventions are short term and they deliver information at one point in time. So when we're thinking about a one pager or some sort of outreach campaign, right? This isn't adequate to address the long-standing systemic impacts of racism. This is years and years of systemic racism. Can't necessarily address it with a one pager. Alrighty. If you could launch the next poll, thank you. Does it focus on precise impact? Righty. Few more seconds. Get those answers in. All right. 4, 3, 2, 1. Ending poll. Alrighty. 25% of you say yes. 60% said no, and 15% said you are not sure. Let's click on that next animation, Zaya. No, so it does not focus on precise impact. So these tips are generally applicable to all populations. We could literally take this one page or remove the picture of the Black mama and remove the Black language and add any ethnic group in, and it would be applicable. So it is not precisely focusing on Black mamas. Next poll, please. All righty. Does it focus on systems change? Few more seconds. I'm loving all the participation. Thank you all. Okay, 5, 4, 3, 2, 1, closing poll. Alrighty, I think a lot of you are like, So we have 16% saying yes, 80% saying no, and 4% are not so sure. Next, click, Zaya. No, it does not focus on systems change. So it does not address any social determinants of health, and it doesn't really focus on economic structural barriers that contribute to stress, which we know is largely to blame for preterm birth, and the impact of the ability to maintain a healthy lifestyle. So next poll, please, for reparations. Does it involve reparations? Okay, answers are pouring in. 4, 3, 2, 1. Ending poll. All right. 7% say yes, 91% say no, and 2% say not so sure. That next slide. Alrighty, no, there is no mention of any reparation of any sort in this one pager, nor does it repair the historical injustices by shifting resources, power, and opportunities to racially marginalized groups, specifically in this case, to Black women and birthing people. Thank you all so much for participating in these polls. We really appreciate it. And I love how as we continued on, more of you started to get the gist of, maybe this isn't really an RRC. Go ahead and take it, Zaya.
Cool. So now I want to tell you a little bit about what we're doing here in San Francisco, and then we're going to take it through that same criteria to see if this is an RRC. So I'm going to tell you guys what we're doing. It's called the Abundant Birth Project. I love talking about it, so I'm going to get really excited, so bear with me. So the Abundant Birth Project is basically a program where we're providing a monthly stipend of $1,000 a month during pregnancy. We're starting as early as we can get to in pregnancy, and we pay until 6 months postpartum. And we have enough funding to pilot this with 150 Black and Pacific Islander pregnant people. So you have to identify as Black and or PI in order to qualify. As far as we know, it's the first of its kind in the United States, but this has been tested in Mexico and in Manitoba, Canada, not in a racially specific way, but with low-income populations. And it's done a wonderful job for reducing preterm birth. So we feel pretty positive about it. For right now, our program is funded primarily through private dollars, through philanthropy. And we started enrolling people on Juneteenth of 2021. We have 15 mamas currently receiving the income supplement. We felt really strongly that we wanted this to be designed with and by community. And so we worked really hard over the entirety of 2020, frankly, and half of this year to design it. And so to start with, we recruited and trained 4 people who identify as mamas and who identify as either Black or PI and have close connections to San Francisco. And we trained them in qualitative research, both in qualitative interviewing and in qualitative analysis. We also trained them in design thinking. And then they in turn went out and they conducted almost 24 in-depth interviews with Black and PI mamas from San Francisco to understand what would you want in a cash program? What do you think will work? What might not work? Like, how do you want it? Do you want a credit card, a check, a cash? Like, tell us. And then we kind of continued to ask similar questions through a design thinking sprint. We had 2 of them with mamas from the community so that we could really have community answer very specific questions for us, like what happens if the baby dies? What happens if CPS gets involved? What do we do with the money? And so in that way, we were authentically able to hand over the keys to community to be able to let them decide some of these critical questions for themselves. We pay for community expertise because we recognize that that form of expertise is at least as valuable as other forms of expertise that we gladly pay for, things like building websites or doing statistical analysis. We couldn't do our work without community expertise, and so we pay them at the same level that we pay our other experts. And we write all of our grants with that level of payment in mind.
Why? It's going to smell.
And then when we got through all of this process, where we landed. Oh, sorry, Annabelle, do you mind muting yourself? Or Peja, if you see, thank you. And so after going through that process, where we landed is this was the eligibility criteria for the pregnancy income supplement. So you have to be within the first 2 trimesters of pregnancy because we want enough time to be able to impact your pregnancy, and you have to be planning to parent. You have to identify as Black and or PI. You have to be a San Francisco resident. You have to earn less than $100,000 annually as a family. And other than that, it's completely unconditional, including with the research. You do not have to participate in our research if you do not want to. The way how it works is that people can self-refer or providers can refer folks. And then that in turn will trigger you to schedule a Zoom intake interview. During the Zoom intake interview, we'll assess your eligibility, look at the paperwork that we need, and also ask you some interview questions to assess your racial identity. If we find that you are eligible, then we enter you into what we call the abundance drawing, and we do that every 2 weeks. If you are in the abundance drawing because you're eligible and you're not selected on a given week, then if you are still under 6 months of your pregnancy, still within the first 2 trimesters, then you are automatically re-entered into the abundance drawing for the following abundance drawing. And that will keep on happening until you get into your 3rd trimester. If you're not selected and you're out of the first 2 trimesters of pregnancy, then we try to refer you to other resources, but you're no longer eligible. And then, of course, for the mamas that do get selected, we invite you to join the Abundant Birth Project, and we move into an orientation with our abundance coach. We also invite the people who are selected to participate in our research surveys so that we can collect data as to whether or not this intervention is having an impact. For the clients, the experience looks like this. First, they go onto our website and they fill out the interest form. And then they are invited to create a dashboard account. And then they will be invited to schedule their intake call through the website. And then they'll be invited to submit their documents, which they can do with their smartphone by just taking pictures of it. And we're requiring a pregnancy verification letter and proof of San Francisco residency. That's the only paperwork. You'll get notified if you are eligible for the drawing, and then you'll get entered into the drawing if you agree. And then we will randomly select people every 2 weeks, like I mentioned. And if you're randomly selected, you'll start receiving the supplement. And then hopefully it will culminate with you having a healthy baby. This is a pilot program, so we're learning as we go. And so one of the things we learned early on was that those steps are very confusing. But when we were going through the design process, we couldn't figure out a less confusing application process. And so we started creating infographics for potential clients and providers to make it a little bit clearer and more transparent what people can expect. And so you can go onto our website and you can see pretty easily right from the top how you can get to the interest form or the dashboard login. This is how you create that dashboard login. So again, pretty straightforward. And then this is what the dashboard looks like to help mamas kind of keep track of the steps of the application process. We also created a dashboard because in the design thinking sprint, we learned that it might be really hard when you're pregnant to get a phone call every 2 weeks saying, sorry, you were again not selected. Sorry, you were again not selected. And so instead we wanted to make it so that mamas can just check on their own to see what their selection status is. Okay, and so also what we've learned is that we needed to create an infographic for the intake call to help mamas not be nervous about that and to know what to expect. And so we now send out this infographic before the intake call so mamas can know what we're going to be covering and what they can expect. And likewise, we got really clear about what documentation we need, although we're finding that this is evolving a little bit as we're seeing what documentation is actually working for what we need and what doesn't. And we've worked really hard based on what we learned during the interviews and the design thinking sprint to make sure that everything can be done over a smartphone because that is what is the most accessible to the largest group of mamas. When we call moms to tell them that they've been selected for the abundance drawing, we created a special little celebratory background that has animated confetti so that we can celebrate that and make it a joyful experience for them. Another thing that we feel really strongly about is that early on in our research, mamas kind of let us know through their interviews that there could be a stigma associated with this, in the way that there's a stigma associated with receiving other kinds of benefits like CalFresh, CalWORKs, and WIC. And so we've been working really hard in our messaging and our imagery to try and counter that stigma and to have this be something that you feel proud of. So the debit card that mamas receive, where they're going to get their $1,000 a month, it's renewable, is something that we hope people are excited to feel like they're members only club kind of situation. So this is what our debit card looks like. And likewise with our outreach materials, we really wanted to create imagery that painted mamas as beautiful and royal and deserving, as opposed to mamas as pathetic and needy and poor. And so we really wanted to reflect this kind of abundance and this sensibility of abundance in these communities through our imagery. Okay, something that people are always curious about is for people who are already receiving benefits, when you raise their income, what's going to happen? So it turns out, had to become like a policy expert over the last year. And we've been working really hard at the state and federal level to get waivers for each of these benefit programs. And so early on, actually, and thank God, one of our first victories after working with the San Francisco Housing Authority and HUD at the federal level is that we got a waiver to protect anybody who is living in Section 8 housing or public housing or receives any other kind of federal public housing benefit. That will be protected, and we won't be counting this increase in the income towards your housing benefit calculations. We also got a ruling from our city attorney that this will not be taxable by the IRS, so mamas won't have to pay taxes on these dollars. And if it's not taxable, then Medi-Cal does not consider it income, so it will not impact people's Medi-Cal status. We've been working with Legal Aid at Work, which is a legal advocacy law firm, and they basically created a letter for our mamas that says that the EDD should not count this money as income when they're calculating your disability. They should count it as a gift, so it shouldn't count against you. And basically, mamas can submit this letter, and if they still get static from EDD, then Legal Aid at Work has offered to go to bat for them. So all they'll have to do is just contact one of their lawyers. For CalFresh and CalWORKs, we've had to submit a waiver at the state level with California Department of Social Services to request that these get waived. And we feel positive that we will get that waiver, but we're just in a waiting game right now. And we had a WIC waiver initially at the local level, and that was really exciting, but the state started to get overwhelmed because there were so many local agencies requesting a waiver, and in the absence of guidance from the feds, they were nervous that we were getting too far out of the WIC charter. And so they pulled the waiver, but they're still very supportive. And we're now doing federal level advocacy to try and protect WIC for all basic income recipients. And lastly, I want to I'm going to hand it off to my colleague, Tasia, to talk about the research.
Thank you, Zaya. Appreciate it. So as we all know, evaluation and research for any program is important. So we're going to talk a little bit about how we collect and analyze our data for the Abundant Birth Project, our evaluation design, as well as our outcomes framework. Next slide, please, Zaya. Alrighty, so something that we love to always mention, something that we believe is very important to our research are our community researchers. So as we mentioned earlier, community is very much so heavily involved in the Abundant Birth Project pilot. So without our community researchers, our work would not and could not be truly community and equity focused. So even looking back to the racism as a root cause approach and thinking about reparations and what it means to share power, what it means to shift resources and opportunities, this is what we're doing with our community researchers. Our community researchers are paid for their expertise and for their time. So once again, by including and centering community researchers from the racial groups that we're focusing on, we're working to improve preterm birth rates for equitably and also equitably compensating them. So there's a picture from some of our researchers. We have Breezy, Sabra, we have Anjanette, and we have Miley, and they are all from either the Black community, and we have Miley, who also represents the Black and the Pacifica community as well. Next slide, please, Leah. Alrighty, so something that we kind of want to get your wheels turning a little bit, right? So obviously our pilot is specifically focused in San Francisco, but what we want to ask is what might community researchers for Riverside and San Bernardino County look like, right? So how much your Riverside and San Bernardino County clinics or programs work to not only include community, but also to ensure that community is being equitably compensated for their time and for their expertise. So think of your program, think of your clinic, whether it's a maternal health program, whether it's a nutrition program, whatever program that you specifically work for, and start to think of ways that you could possibly involve community researchers and community. And if you could drop your answers in the chat, I'll give a few seconds and share out a few ideas if you want to, but really want to start to get your wheels thinking and kind of thinking about how to really implement this type of research. Zaya says, pay your community advisory board. Absolutely. So something that we know specifically for even FQHCs, right, is that it's mandatory, like for government funding, right, that you have a community advisory board. I remember specifically, I worked for a SNF in San Bernardino County, a skilled nursing facility, and we had a community advisory board of all of the patients, but they were not paid for their time and they were not paid for their expertise. So I agree. Dr. Ragurio agrees with Dr. Malawa. That should be a good place to start. Dr. Kendra says, partner with professors/researchers like myself who work in academia. Absolutely, always looking to involve academia in real life application. Denise Smart says, if you do not have funding, can you develop a certificate for training that they can use in their future resume? Absolutely. So something that we actually focus on at Expecting Justice is we do what's called capacity building with our community researchers, where we bring them in and we take all the skills that they're learning, right, and we apply it to the resume. How can this help you in your future and presently? ST Bryant says, pay families who participate with focus groups more than what is usually offered. Absolutely. A $25 gift card to Starbucks is not enough for expertise. Dr. Reguero also says, what about hiring community members as consultants? Absolutely. That is also something that the Abundant Birth Project heavily believes in, and Expecting Justice, that's part of our ethos, is hiring folks from the community, from the Black community, from the Pacifica community, as consultants, independent consultants, to help us with the work. Once again, centering community voices. Thank you so much, everyone, for participating. Now we're going to talk a little bit about our ABP pilot evaluation and design. So as mentioned, the Abundant Birth Project is a pilot program, meaning it is a feasibility program, right? So starting from the beginning, we are starting with exactly how it works. We're starting with a random abundance drawing. So we're not selecting the participants who are being entered in the drawing for the Abundant Birth Project. It's completely random. And we are looking to enroll 150 mamas over a 2-year span. So obviously I want to point your attention to 150 is not a strong enough sample, right? Of San Francisco, let alone California, to say specifically that this income supplement is going to have a precise impact on preterm births. However, we can look at the risk factors, right, that go into preterm birth, right? So we're taking 150, and then we're also looking at, go back to the next slide. Thank you, it's okay. We're also looking at taking neighboring counties as our control group. So the Abundant Birth Project participants are the case group, and then our neighboring counties, they'll be the control group, comparing what it looks like for those who are receiving the program and those who are not receiving the program. However, I do want to mention that those neighboring counties, those who are in the neighboring counties control group will be compensated for their time and their expertise. All righty. Okay, awesome. Then we are looking at evaluating at several different points, 4 different points. We're looking at the time of enrollment, right? So as soon as that mama makes it through the drawing and she's selected, we're also looking at time point 2, which is in the 3rd trimester, time point 3, which is 6 to 10 weeks postpartum after having baby, and time point 4, which is 6 months postpartum. Next slide, please. Alrighty, and then just want to quickly move through some of our outcomes framework. So we are hoping that all of the following factors will be addressed with the ABP income supplement, specifically looking at the following outcomes: food security, housing security, obviously maternal stress, which we know is a big factor in preterm birth, kinder readiness, and mental health, right? And the idea is that these will yield better health for moms and babies. Next slide, please. Go ahead, Zaya.
Great. So just briefly, I want to take us through this. Let's decide, is this a racism as a root cause intervention? So is it long-term? We're hoping so. Before we even started this pilot, we started looking at pathways for sustainability. So we started pursuing at the state level SB 65 that we introduced at the beginning of this year. Also, the child tax credit might provide another opportunity, and we have some things cooking at the local level as well. Does it have a precise impact? We believe so, because this was specifically designed by and offered to Black and Pacific Islander folks, who are the people at the greatest risk of having an adverse birth outcome. Systems change? We think so, because this provides resources to overcome barriers rather than expecting individuals to take responsibility for structural problems. And lastly, reparations. We've been very intentional to shift resources, decision-making power, and opportunities into the communities we're trying to support. I briefly want to mention the California Omnibus Bill, SB 65, that we've been working on this year. So this bill is headed towards the governor's desk, and we're hoping he's going to sign it. If he signs it, it will provide funding for diversifying the midwifery workforce here in California. It will remove the work requirement for people on TANF, on CalWORKs, while they're pregnant. It will extend pregnancy Medicaid permanently through 12 months postpartum, so that we will no longer have it on a trial basis. And because the governor feels so strongly about early childhood, he actually took a couple of provisions from this original bill and put them into his budget so that they would for sure pass. And so what he already took, that is already a done deal, is that we now in California, as of January 1st, and I can't believe it, will have full spectrum doula care as a covered Medicaid benefit. So yay. And also he put aside $54 million over 3 years to provide matching funds for any county that wants to pilot a pregnancy guaranteed income program themselves. So if you do private funding or government funding, local government funding, the state could potentially match you dollar for dollar so you could do your own pregnancy income supplement project. So is SB 65 an RRC? We like to think so. We think it's long-term. We think that some aspects of the bill have a precise impact, so that's why it's a little check mark. We think it focuses on systems change. And because marginalized birthing people stand the most to gain, we think that it also addresses reparations. I know we're close to time, but this feels important to me, so I just want to talk very briefly and close here with how y'all can uproot racism in your own gardens. We have a poll, but I'm just going to move through it. So first, when you think about long-term, in what ways does your clinic or program prioritize Black and Indigenous communities in its long-term strategic planning? And how can your clinic invest in long-term solutions that will improve health outcomes? So it's really worth it every time you guys get to that place where you're doing strategic planning or budgeting to think about what long-term investments can we make in these communities. And then precise impact. What proportion of your clinic's work is specifically focused on health outcomes for folks who experience adverse outcomes? And how are you measuring success? And how might your office become a space that Black and Indigenous people love to go? Not just tolerate, not just increase your numbers a little bit, but that they actually feel truly welcome there. And how does your clinic or program work on implicit bias among staff? Implicit bias in particular directed towards Black and Indigenous people. And as a reminder, Latino people also include Black and Indigenous folks, right? So when I'm saying Black and Indigenous, it's not to the exclusion of Latinx people. The most marginalized Latinx people are also Black and Indigenous. Systems change. How are we focusing on changing systems in our work? How does your program account for racism when you're providing counseling for families? We can say all day you need to go take this blood pressure medicine, but are we accounting for the fact that they may not have transportation, medication coverage, or that the ongoing chronic stress might be actually driving their high blood pressure, not a lack of medications? How might your clinic or program make it easier for Black and Indigenous communities to access services? What policies and practices can you change in your clinic to make it easier specifically for these communities? If it reaches other communities too, great, but how do you center specifically these as you think about your practices? And then lastly, reparations. How can we start to share decision-making power with prioritized communities? How can we prioritize Black and Indigenous communities in our annual budget? And then how can we ensure that our Black and Indigenous staff, not just our patients and clients, but our Black and Indigenous staff have opportunities to grow in their career, have access to leadership positions, and can do authentic decision-making for the program? So with that, we're going to conclude. I hope that everybody feels slightly more equipped to get out there and create an abundant future. Of course, I want to thank our wonderful funders who have made the Abundant Birth Project and all of our work possible. And of course, we want to thank you all for your kind attention. And in these last few minutes, it would be our pleasure to take any questions that you have. Thank you.
Thank you so much, Dr. Zaya and Hasia. We literally have like space for one question. And I would encourage somebody to unmute themselves and ask their question live before we have our 30-second wrap up. But I did want to give you the opportunity to ask that if you had it.
Hi,
I'm sorry for getting us there. Please, come on.
Yeah, my question is, where have you had your program implemented? Has it been implemented throughout in different hospital settings or?
No, this is the first of its kind. We just started in June and it's only in San Francisco. And so, yeah. And so we're just testing it out and we're going to see. I don't work with First 5 California per se. I am just on the city, San Francisco level First 5 commission. But I know that we've been doing a lot of anti-racism work at the city, San Francisco First 5. And when we have any kind of success, they do try and push it up to the state level. We will be publishing our results about the Abundant Birth Project as they come. And we're a little bit behind just because we're a tiny little team, but we're hoping to publish our initial findings from that initial community researcher-led work that we did about what the community needs looks like. We're hoping to publish that out in the coming months. And we're also hoping to try and be on top of both academic press, but also popular press so that it's accessible to multiple people. And lastly, I'll mention around publishing that we're trying to also push this narrative because there's such a harmful issue of this idea of the welfare queen in this country. And it makes it really difficult for Black women to feel comfortable about receiving help. But also it creates a situation in which a lot of Americans feel really uncomfortable with providing racially specific guaranteed income programs. And so we're hoping to use any kind of media attention that we get from the Abundant Birth Project to also be able to kind of challenge some of those notions around deservedness and welfare queens, et cetera. So what outcomes are we measuring? I know that we are almost out of time, but I will just briefly say that we're measuring financial well-being, a sense of hope and wellness, and then obviously medical and educational outcomes for mom and baby. All right. Thank you so much, San Bernardino and Riverside. It's been such a treat to be part of your anti-racism series.